I was a student athlete when I was an undergrad, and the one thing I can tell you about the rivalry is it was great when you were competing. I was running track and cross country, and then afterwards everybody hung out together. So other people got mean about it, but when you were actually like people competing, like you were friends with everybody outside of it. So that's the dirty secret. We all get along. Sorry, it's not that mean. So I got a ton of slides. Part of the point of this is that you can have the slides and you can see them afterwards, and use, adapt, credit where appropriate. And if you have questions, reach out. I know that I had a couple of tweets back and forth with somebody ahead of time. That's great. Happy to always engage people in whatever way would be helpful for them. There are very few people that have sort of done some of this stuff, and a few of us who have more of a regulatory background combined with a science and tech background, we've kind of made the decision we're just going to proselytize, and we're going to give away as much good thinking as we can in the hopes that people avoid real problems. Because we've already started to see some cases where we've been a little concerned. And so the idea is if you teach the community and you create a community where people trust one another and work well together, you can avoid some of that. So that's kind of been my approach to it. So all these slides are available. You can have them. If you've got questions, ask. Jump in. Something's confusing, jump up, ask a question. I start with this because this is the hard part. As somebody who teaches in ethics and public policy and has worked in sort of thorny and complicated science and tech issues, like stem cell policy and things like that, I see a lot of this as a moral obligation. And we have systems and structures that currently don't work, and it's kind of on us collectively to not reinvent the same broken systems. And there's a number of risks that are associated with doing that, and I've sort of broadly laid them out here. So this is the way that I think about this. And it's kind of what I think we all can do if we think a little bit ahead of time, be a little more methodical about how we approach things, and take the time to deliberate before just doing things. So this is probably, I say it's the most important slide. If you can remember this, you've probably gotten the most benefit from this talk already. So, yeah, there's a definition issue. I fall into I don't know if it's a camp or a group, or maybe I'm just lazy. I think they're all the same thing. At one point in time, we thought of health IT back in the day. If anybody's ever heard of HIMSS, HIMSS is like the oldest health IT group in professional society. They've been around for a long time. And at a basic level, they're like, oh, it's informatics and it's applying technology to healthcare settings. Cool, all right, well then we started to kind of figure out we had more tech we could do in other areas. And somebody came up with this idea that maybe there's this thing called digital health or health in the digital age. And then they said, ooh, if you can walk around with it and it's not attached to the wall, it's mobile. And we have mHealth, and I just think that it's kind of pointless. They all blur together. So I use these interchangeably, but I've been trying to be more disciplined and basically just say digital health. Okay. I've given this slide a few times before, and I think it's important to kind of frame the conversation. We have to make a distinction, especially if you're an IRB or somebody putting together a protocol, between whether something is just something you're unfamiliar with, whether it's just a new version of an old way of doing a given task or action, or whether something is truly novel. And that helps, especially in a regulatory environment and a policy environment, kind of put you down a path for what questions you should ask and what things you should consider. And it also helps you understand how you should explain what's going on as you teach others what you're doing. And so a large part of this is teaching people what you're doing and telling what you're up to so they understand it, so that they can either evaluate it or engage it in some way. So there's a kind of a teaching mandate from all of us in this community that we have to be sort of aware of. So with unfamiliar stuff, this is, oh, I've never heard of that. Okay, great. Well, that's just a basic teaching thing. This is what it is. This is what we're doing. With stuff that's just newer versions of old things, the best example I have is we started off with validated instruments that we gave to people on a piece of paper with a pen or a pencil, and we had them fill them out. Then we discovered Scantron. I'm a child of Scantron. And we filled out little bubbles. Then we got to the point where you could do it on a computer desktop, Apple IIc, if anybody used that. Oregon Trail. All right, so we went down that road for a while. Computers got smaller, more powerful, et cetera, and then all of a sudden we had touchscreens, we had stuff that wasn't plugged in, and we got into tablets and mobile. But you're still using the old, same validated instrument. It's still just a survey. So it's new technology applied to an old task. It may not have that much that's different about it in terms of risks or other things. So you may not actually have to worry about things quite as much as people do worry about them. So new seems to create fear, but if it's just a survey, there shouldn't be a problem. But the last bit is whether something's truly novel. And this is where we get into novel combinations of previous things, or new ways of collecting data that you've never been able to collect, or new kinds of platforms and technologies that really are fundamentally novel. So this is the part where you kind of have to do both. You have to teach people what it is, but you also have to go and be above and beyond, and you have to describe everything in a much greater level of detail and kind of map out that you've really thought it through. So the heaviest lift is if something is truly novel. What I would argue is most of the digital health research that I've seen isn't novel. And that's okay. There's absolutely nothing wrong with it. Some of the biggest benefits we're going to get is from non-novel research that's just going to be really good. When you create efficiency, when you make things meet people where they are, when they're designed in such a way that it engages them properly, that it leads to retention, that it leads to adherence, that it gives good outcomes, it doesn't have to be super sexy if it works. So I think few things are truly novel, but when they are, we have to raise the bar a bit. Okay. As somebody who comes from sort of a science and technology policy background at certain points in my career, I try to think about it in this way, and this is the way that I tell IRBs and others. You take it, you acknowledge that technology is in continuous development, you take that as a truth, and you don't worry about it. We're not interested in engaging Luddite behavior. And then you kind of overlay our current thinking in order to understand what stuff we need to do, what stuff is the same as before, and what stuff might be new. Okay. So this is where we're going to start kind of going in a different direction. We have sort of two things that happen. You got to build a team, and then you have to go build a product if you're thinking about it as a company or somebody who's got a solution. And there's a lot of different things we have to think about when that occurs. The first is that Silicon Valley and healthcare technology and healthcare systems are kind of different. If anybody's ever watched the show Silicon Valley and you think to yourself, if those guys were developing an EMR, how would it look? And you would probably shudder. And that's okay. But a lot of the problems with how these two communities either interact or don't interact quite so well yet has to do with interdisciplinarity. This is thankfully not a new problem. Interdisciplinary research is hard to do, but there are some groups that have tried to tackle best methods and practices for it. One of my favorite was this group at Harvard a number of years ago, and I'm always forgetting the name of it, but they had some white papers on how to put together and manage interdisciplinary teams, and it had stuff like make sure you acknowledge the contributions of the people you're working with. Like some real fundamentals where everybody's like, well, yeah, that would be really great if I had that on a day-to-day basis. There was a number of things you can do. So if you approach it as an interdisciplinary problem, you just have to know that all of those issues kind of come along with it. And you have to recognize that these communities approach their work in different ways. Somebody who is a full-stack engineer living in Sunnyvale, California, who used to work at Yammer and then at Microsoft integrating things and knows how to build a data warehouse, may have not a clue what PHI is and what the identifiers are. And that's okay. It's not because this person isn't smart. It's because they're smart in a different area. And so we have to build these teams and bring them together in ways that most people are not familiar with. And they don't focus on it. So I tell people you really kind of have to pay attention to these details. The next piece is on the building the solution. In some cases, I think that a number of digital health platforms are actually novel study designs. This can be really confusing. If the platform itself is the study design, you have a device does a number of novel things or a novel combination of different types of data collected in settings where we previously have never been able to collect them, and then you want to see how people use it, whether there's a feedback mechanism that's really working, whether they're getting some outcomes, and you're tracking all kinds of different stuff. The platform itself might actually be a study design. which is we want to use this type of platform. And that's a new way of doing it, because in the past you might have had study visits. You're going to come in once a week and you're going to sit down, you're going to do whatever, a structured interview and some tasks. We might take some blood from you or what have you. But if you're no longer doing it that way, the entire way we think about study designs could be changing. And so we have to think whether what we're doing is either similar to a standard design that already exists, in which case describe it that way and talk about the similarities and differences, or if you know it's truly different, say that up front. This is different, here's how it is different, here's how it's still scientifically valid, here's how it's still going to address certain questions that we want to ask, but we need to be thinking about this. And a lot of this is directly tied to the technology itself. And so having a detailed understanding of what the technology is, how it's working, and what you're doing, and then being able to communicate that effectively becomes way more important. So back to these bits about the interdisciplinary struggles, this is just some recommendations about it. Be better partners, manage these things better. And if you're an IRB or somebody who's overseeing a project, or it's your lab and you're the faculty member, put thought into this. Have plans about how to do this. Know that it is an issue. It is an issue that is independent of your particular team. It is a collaboration issue generally. And if you have things that are difficult enough to tackle to begin with, it's worth putting the effort into this part of it to pay it forward for yourself. Okay. As a former IRB chair, an IRB member, a lot of this I'm going to couch in terms of research ethics, because it can help you in terms of design and conduct of studies to think about these issues ahead of time and kind of map them out to the places where somebody who's going to be reviewing them will be thinking about them. I will point out you have some local expertise here at Carolina, people that I've known for many years and respect greatly, one of which is in this room. So John Roberts and I work together at Mount Sinai, and it's unfortunate they no longer have him, but it's really fortunate that you have him here at Carolina. So he is a resource that you can draw upon. He's somebody that I've worked with for a long time, and he's really good. So just know that that he's here. Sorry, John. You're going to get an extra 20 phone calls. And he knows how to find me and be like, why did you say that? But I like to point out people that are really good. It's a thing in the IRB community that we try to do. So we're going to talk about this in terms of the three sort of big areas in research ethics. If you consider the Belmont Report, which is, it's like chapter and verse. It's like the Bible for research ethics. We constantly go back to it. And we think about it in three ways. We think about it in terms of autonomy, and this is commonly thought of in terms of what we do for consent, and we'll talk a bit about e-consent. We think about the risk-benefit calculus and those kinds of determinations, and we'll go over both new or different types of risks, as well as increase or change in magnitude of risk. Both of those things actually impact determinations, and they have real meanings, and within digital health and health research, there's actually some nuance there that's just worth going over and thinking about. And the last part is justice considerations. And in some of these, we actually have some opportunities for doing some really great things, and hope to kind of challenge you and give you the sense that you can do more, and that you might be able to provide partial solutions to problems that have been plaguing clinical research and research ethics for decades. And that's something that, as a community, we really want to see happen. So autonomy. This is really all about consent. So the first thing for everybody to know is that a EULA is not a consent form. And this just reverberates through in so many ways. One of the biggest problems I've noticed in this area of EULAs are not consents is around wearables and devices that you're going to then use in trials. And part of that is, let's say you've got a Fitbit or a Jawbone. We'll take Fitbit. Has anybody ever read the EULA for a Fitbit? Okay, privacy officers and lawyers. Cool, thank you. All right, but here's the thing. Here's the thing. This is great. So if you're thinking about using one of those devices at your institution to do research, those are the people you talk to. You get your general counsel on the phone. You get your privacy officer, and you go, okay, we're going to write this consent form up, and we're going to do this, and we're going to have this study, and this is broadly what we're thinking. Is there anything that will contradict that or cause us a legal issue within the EULA? Because if there is, you've got to sort that out first. And what I would argue is the regulations and human subject protections are way more sturdy and way more important than some companies' EULA. Yours wins, yours trumps, because it's law. So if you've got an issue or you conflict, go back to the company and start hammering them. Nobody here works with Fitbit. Good. I don't want to pick on them. They make great devices. But it is an issue that's coming up because they may have things that are written in the EULA about using your data, potentially selling your data, or sending to other people. And if they're keeping copies of things and then you're turning around in a consent form and you're saying something that's typical of a HIPAA privacy disclosure where you say your data will not be sold or shared with a third party unless it's going to be shared with these ones, these are the ones that they're going to be shared with, you don't want to be saying something wrong. And you don't want to be telling something to a subject or potential subject that's not true. So you got to be careful. And this is an area that's going to lead to problems. And I've already seen studies, I won't say who, I won't say what, but I've already seen things where I think what was actually put in there is not correct. So we need to be thoughtful and we need to do it quickly, and we didn't do it on the front side. And we need to teach some of the device companies how to do it right. Because if you go to them, you can't assume that they're just these mean corporate entities, right? They are creating a product, and most of the time they wanted to create a product to help people. And so you got to tell them, hey, this conflicts with what we're doing, but here's a solution we think we could do. Teach them, bring them something they can make actionable, and work with them to help them develop a way and a path forward. All right, that's my spiel on that one. So let's talk about some e-consent systems. So I got into this sort of by accident and sort of by interest. When I was in graduate school over at Duke, I worked on virtual reality technology, modeling protein structures in a 6-sided VR system. We interacted a lot with the people at Carolina. As some people may know, UNC's computer science department, founded by Fred Brooks, has been a leader in VR technology for 40 years. He was the first person to do force feedback systems, head-mounted displays, infrared trackers, ultrasonic trackers, etc. The kinds of stuff you're seeing in VR right now, they're like 1975. That's kind of what they did. They're great. And so I was working on that. So I've been leading and pulling together interdisciplinary teams to build technology for a while and really loved it. When I was at Mount Sinai and I was one of the IRB chairs, we were approached by a couple of faculty members within one of the departments that said, hey, we want to do this thing. We're like, what is it? And they're like, oh, we want to build this app, and we want to do it, and it's going to be for an iPhone, and it's going to study asthma. And here are the 10 ideas on what it is. And I was like, that's cool. The first 5 are illegal. The next 3 are okay. And then 2 of them are easy. And they're like, what? And I was like, well, and I looked at my boss of blessed memory and said, maybe I should take my IRB hat off and wear my faculty hat and work with them and help them design this in a regulatorily approvable way. And so that's how we started working on the asthma app. It was one of the first 4 research kit apps that Apple debuted about 18 months ago, something like that at this point. It was a lot of fun. I got to work with some great folks, a pulmonologist, an ER doc, and some others. And I really pushed for a number of things to make sure that they were included. It was to the tune of taking somebody who was a technologist and being like, listen, here's a copy of 45 CFR 46. You've been arguing with me for 4 days. I want you to see the regulatory environment that we have to exist in. And when you read this, you'll realize I'm being nice. And he sort of came back about an hour later. He's like, okay, let's talk. So we try to develop some ways to do this better. Not just say, okay, how can we get it over this ground to minimum necessary? So, okay, how can we actually do it better? How can we try to increase informedness of people, et cetera? And we had help from John Wilbanks at Sage Bionetworks, who's great, and I count him as both a friend and sort of a thought partner. And we have this method that's essentially layered consenting, and it has a number of different ways that we do it. So this is a little bit about the app. These are some recruitment numbers. That's kind of insane. However, when your recruitment strategy includes Tim Cook puts your app on a screen and talks about it for 5 minutes, you get numbers like that first column, right? Or that first row. And it's like, oh yeah, 49,000 people download it in 24 hours. And you're like, oh. Thankfully, we thought about that ahead of time. And so we said, there is the potential for the recruitment numbers of this study to be upwards of 70 to 80,000 people in the first 6 months. It was written in the protocol. And when I wrote that in the protocol, they thought I was crazy. They were like, no, this is, a pulmonologist is like, I would be super happy if we got 500 or 700 people. That would be insane. It would be great. And I was like, you're going to get that in 20 minutes. Tim Cook's going to talk about this. The logo is going to be on a screen. at a developer conference that the world watches. So it was interesting. We got a ton of people into it. What was actually additionally cool is that it still, after the hype went down, accrual still stayed at a fairly high level. To my knowledge, having looked through the literature, this is the largest cohort of asthma sufferers ever assembled into a single study. It's insane. So we have this study. It's pretty cool. It does a whole number of things. It is basically a glorified log. It takes information from you. You do some tasks that are surveys. It can feed up some information that's helpful to the participant. Things like, what's the pollen count where you are, based on an API connection to the National Weather Service, and how much did you use your inhaler, et cetera, et cetera. We also included in there educational material, and a lot of that came from validated things that had been done by National Jewish, and had come out of Colorado. And so almost everything that is done in here was designed on purpose to fall within the categories of minimal risk, so that it could be done through expedited procedure for an IRB. And I pushed on them about this. This is before the FDA guidance. And so I kind of looked at them and I said, listen, you can't do anything that is directive medical advice or would imply a relationship, a care relationship between the people running this study and the people in it. And they said, why? And I said, okay, we have one pulmonologist on this study. And I looked at her. She's wonderful. Her name's Linda. And I was like, Linda, would you like to have responsibility for 50,000 people across the United States as their doctor and pulmonologist? And she looked at me and was mortified. And I said, that's why we're not going to have any medical advice that's direct, or anything that's directive, or anything that implies that there is a relationship between patient and doctor through this app. Because we can't do that. And it's, if we told general counsel that you were considering doing that, they would probably flip out for good reason. So that's where a lot of that came from. But we had to think it through. It wasn't immediately obvious that was the case. It's like, well, of course, if we can tell them things that will help them, we should. But we usually do that within a context, and that context is an established relationship, and it both has legal and other attributes to it that really matter. So we have to think about it. So this was characterized and pushed to keep it within minimal risk, and to keep it so that it wasn't directive in that way and didn't imply any of that. And so drafts of this had stuff that we had to constantly pull out. I was just, nope, you can't say this, you can't say this, you can't say this. And they got it. I mean, it took them a while. They learned it, but they got it. And that's part of the process of crafting a study in digital health. Like, you have to go through that back and forth with people that have different expertise to kind of learn it and take it to the next level. Yeah?
Could you give an example of something that maybe was included in an earlier version of the app but had to be taken out?
Well, I can talk about what was included in discussions. Nothing ever got into the app that shouldn't have been there, thankfully. So this was all pre-submission to the IRB. I'll give you an example from a different company and a different app, not from this one. That way it can protect, identities. But at one point someone said, can we include a picture and some information in order to try to guilt somebody into participating in this? Literally, I have it in writing. Can we include this that would guilt them or make them feel compelled to do it to try to convince them and persuade them? And I said politely back, absolutely not, but here's why. And it was because this person came from consumer tech and had come from an area within social media where that's common practice. Not only is it common practice, they have specific methodology for it. And they do it on purpose in order to do things like advertising technology. And so there's, it's a different set of influences and backgrounds. And when I explained it to this individual, they got it. But it just had never been brought up to them before. Does that answer your question? No, maybe. I can give more if you want later. Yeah?
What technology was used to monitor lung function?
So if they had their own, they could do a spirometer and then input information. And then this was going to be forward leading. So at some point, if somebody had a Bluetooth enabled inhaler or spirometer, they could actually connect it up and then auto drop the data into it. So those were the things that were on it. But it was still, what are you using? And a number of these things were optional, and then only a few of them were sort of required.
Were the results published?
The results are not published yet. They're still, I think this is still actively ongoing. So the results are not published yet.
If you weren't providing any feedback or anything directive, that just simply self
It does. More or less it does, but there's all sorts of problems with that statement because the people who use this may be early adopters. They may be people who are more interested for some reason or another in managing their symptoms. They may have had something happen that put them in that position. So I put a big asterisk next to a lot of these kinds of conclusions because of stuff like that. And then being able to segment them out and say, okay, what's the mean age of these people that are using it? What is their technology usage, et cetera? And so there's a lot of questions around that need to be sorted in order to, kind of baseline different biases out of it, or at least understand the biases. This stuff, right? We can't just keep giving people long legalistic documents and expect them to understand things. The history of research around consent has indicated that people don't get it. They sign it, and then you ask them afterwards, and you find that they don't understand what they just signed. And so we need to do better, and at least try to use technology to do better when we have the opportunity. The other piece that I really pushed for initially, I hope this is just going to become a foregone conclusion for everybody, is quizzing people. You have very easy ways of asking people questions and then quizzing, and I think it has a regulatory home. Because it's going to, if you're doing entirely remote electronic consent where you're not going to interact with an individual directly, this is going to be a proxy for that discussion at the end where the investigator says, do you have any questions, or asks them a few things to confirm they know something about what they're doing. And we have a regulatory and ethical mandate to do this because we need to try to verify that people understand things. We don't have to quiz them and try to trick them. And they don't even have to get everything right. They need to have the opportunity to be questioned, and then on this, if they get something wrong, it tells them why they got it wrong and tries to reinforce it, and then they can get asked it again. This is just good instructional design. And so that's the approach that's being taken, and I think it has a regulatory grounding where it replaces that conversation between the investigator or the person getting consent and the potential subject. And then if they can't get it right over a certain number of times in a row, you don't allow them in the study. And this is the same as investigators who are not supposed to allow people into a study who basically say, I will be in the study, just give me the consent form, I'll sign it. I don't need to read it. If that happens, investigators have an obligation to say, no, I can't include you in this because you're choosing not to be informed. So we can start to do things like this here, and I think asking questions is a really good one. So we've mandated in a number of cases quizzes at different points to ask about different things, usually about stuff like privacy, data sharing, and confidentiality, things that are often more confusing within digital health for subjects and participants. So this is the thing that I sort of put on this. I put my name on it because if it's wrong, you can blame me, and you can say it was a terrible idea. I also got it pushed back because when I started really pushing people and saying, we need to do this, we need to do this, we need to do this, I sounded like enough of a broken record. They're like, that's your rule. So I think that because we have the opportunity, the ability to do different modalities in electronic informed consent, that we should. And so the block rule is you should do at least 3. So if it's charts, if it's quizzes, if it's video, if it's something interactive, it's a layered information, you got to do at least 3 to respect the fact that human beings learn differently. Anybody who's ever interacted and done adult learning versus teaching a child versus teaching an adolescent or a college student knows that they have different ways that they learn and different things that work for them. In different cultures, people learn information in different ways. And so the idea of doing multimodality and consenting is respect and honoring and acknowledging that basic fact. So I think that we should be doing it. You should do at least 3. I'm agnostic personally about which 3 you do. Whatever you think works that conveys the information that you're trying to convey in a good manner. And so that's where I put this this out there for people and tell them that that's what they should do. Okay. So these are just some of the benefits and aspects of digital health and e-consent. And they're things that I just think are worth promoting. And we don't have to spend too much time on it, but I think it's sort of a summary of what we've been discussing so far. So that was the first one, and that was about 18 months ago. And it had video, and it had infographics, and it had quizzes, and it had layered information, which was great. What have we done since? well, there's about 2 or 3 dozen research kit applications that are out right now. I've been part of a group with and I always botch their name. It's the Global Alliance for Genetics and Health, or I forget what it is, or it's something like that. And what we've done is we've actually gone and done an analysis of every e-consent system that's been implemented in all of the currently available research kit applications to see how we're doing. And some things are going well, and some things are like not going quite so well in terms of people, meeting the regulations. And I still think we can do better. So the first one that I was involved in was the mHealth one, and it had that layered information, and it had a consent video. The consent video was about 7 minutes long. It was mandated that you could not fast forward through it. We disallowed that feature, which is great, and you have the ability to do that kind of thing in consent systems with the technology. You can make sure that people can't just click, 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 and hit accept. So it pushes people, and it's a forcing function for people to get informed. Well, I looked at it, and I said, okay, I've got another project I'm working on right now, and the company that's helping us build it out is this company called LifeLink out of the Bay Area in California. And I said, well, how can we do this better? And the vice president of the product sort of looked at me, and he's like, people don't have attention to sit and watch a 7-minute video, but we can probably get away with multiple videos that are shorter. I said, okay, so let's think about how to do this better. And so we came up with, and this is what we're currently working on for a digital health project I'm involved with Sloan Kettering and Penn and Sinai and Harvard. And it's population screening for genetics. It's sort of interesting and fun. But we decided that we were going to go with shorter videos, 1 to 2 minutes long, and then after the video on a specific topic, ask the question. So it's going to go video, question, video, question, video, question, instead of doing all this stuff and at the end asking them a bunch of quiz questions. And so it'll do reinforcement directly after it. And again, this is trying to take advantage of what we know from instructional design is actually good, and what the people who have built out, tech for social media and for other areas actually know works. So that's sort of the new approach that we're taking, because I still don't think that the first thing is good. I think we can do better. Okay, so that's a lot about e-consent. Let's talk about risk-benefit. This is like, for some people, especially if you're from a regulatory background or you're worried about describing in your studies what the potential risks and benefits are in digital health, this might be helpful for you. Maybe there's stuff in here that you've already known and been using. Maybe there's stuff where you're like, oh, I never really thought of that. I hope there's a mix of both. So the data security, confidentiality, and privacy are like always the big things. So for privacy and confidentiality, this is really tied to the technology itself and what you're doing and what you're collecting. And so having a deep understanding of that is critically important, and then being able to communicate that. This is an area where IRBs and regulatory people, you want to know what the average age is of somebody on an IRB? Anybody want to guess?
45.
Somewhere around 50 is probably right. The 62 is the average age of an IRB chair. That's close to it. And so, but there's reasons why. And they're usually institutional reasons that has to do with the fact that you need to put somebody there that can be shot at every day. And that usually needs to be a more senior leader within the institution, usually an established faculty member who the dean can't fire, right? And so that's usually why you wind up with people that trend more senior in their careers. And they have a wealth of knowledge and background and understanding of how research is conducted and the ins and outs, and it's a good thing. But it doesn't mean that all of them necessarily are steeped in the understanding of some of this technology. And so we have to do a lot more to teach them. And we have to teach them what's going on, and we have to meet with them and make it digestible to them. Because these are environments where they're insanely under-resourced. IRBs nationally are known to be under-resourced. Oftentimes institutions treat them as cost centers, which is a really bad idea, and go after their budgets. And then they're asked to do the only line of defense for the university or the institution. And so it's here, do this really important function, and we're cutting your budget. And you're like, oh, great. So they're usually kind of strapped. So the more you make it easier for them to do their job, the better. And then IRB members are volunteers. They're your colleagues. They're other people in the institution, and you can't presume that they know. And so you have to be able to teach them and give them the best information so they can make good judgments and assessments and keep everybody safe. So it's really tied to the technology. One of the issues that comes up is this bystander issue. Are you using like a mobile device and having somebody take photos and then you accidentally like capture the face of the person behind them along with their ID card? Great, you didn't intend that, but you now have like potentially PHI or identifying information of a non-participant in your study. There's really easy ways to deal with some of this, which is you say what you would do in those events ahead of time in your protocol. You say, okay, if for some reason someone takes an image and we get information on that image that like we really don't want and we're not supposed to have, our process is identify that image, because we will do something like review them weekly or review them monthly, and then we will go into Photoshop and we will modify it and we will keep the new one and we will get rid of the raw original one and have one and only have a copy that has the thing blurred out. Great. If you tell an IRB ahead of time how you're going to handle some of this stuff, it becomes a complete non-issue. And it's the most low-tech solution ever, but it's fine. And so you can see how there's some really easy ways to get around some of these risks by just describing ahead of time how you would handle it in the event that something would occur. So that's just good planning, and that's typical of people who write good research protocols. So I have been a big advocate for simple solutions like that. And I don't think that you need to say, oh, we need to build in an auto-filtering system that does, recognition of faces and then blurs them out based on a 7-point comparison to what. No, don't go overboard. If you have a simple solution, do it that way. So I think that's one of those risks that we have to talk about. We have to kind of go over consent legitimacy basically to say that most of the time it's not an issue. And the reason it's not an issue is most of the time it's minimal risk research, and you usually don't have to worry about it. And it's as much of an issue in digital health research as it is in regular research. You could still have somebody come up to you and lie to an investigator about who they are. It happens all the time. Does it happen a lot? No, but it's happened in the past. And I don't think we have any evidence at all whatsoever that we're seeing more of it in digital health than we are in the rest of research. If we get evidence to that effect, then we can start to think about whether we have a real problem with consent legitimacy. Otherwise, it's going to be at a low level and it's going to be consistent with everything else. So this is where I would say it's just like other kinds of research. So it's not novel. It's just, okay, we might have people that are not, who they say they are. Yeah.
Would you see an effect of that on whether or not the quantity of compensation that's offered and whether or not the link to sort of join and do these things is unique or not unique? So in our experience, the places where we have this concern is where there is a quick turnaround on a compensation and this link or opportunity to do this is out there in a non-unique way. And then you get one person who may or may not be 18, who may or may not be in this country, turning these around really quickly because they're trying to. And so that's really the challenge where I see where we run into consent legitimacy. It's tied to how you get in and what you get paid.
So for that, if you're talking about limiting it to one jurisdiction, if they haven't done that technically on the back end, it's not a good technical implementation. And so the question is, can you do anything on improve anything on the technical implementation in order to reduce the possibility of it? But if it's something like a quick survey where to give you a $5 gift card to Kohl's, great. I mean, people did it all the time. And you do that at a kiosk in the mall too. And like you could in an afternoon have the same kid come up and do it twice and you might not remember that kid. And they would say that they're 21, but they're 17. And okay, so it happened, but you didn't know one way or the other anyway. And so, it happens at a low level, and I haven't seen any really robust evidence that like it's a really big problem yet. And so I try to tell people to just be thoughtful about it like they would with any other design, and like try not to worry too much about it.
Has there been any research about it? I'm working right now with one of our studies where I'm trying to decide what I'm going to do over a phone screen and what I'm going to do on an online screen, and are people more likely to lie when responding to an online screen or to somebody they're actually talking to on the phone? Whereas it would save me hundreds of man-hours if I could deal with the screening online.
There's not a lot of research on it, and that's why I say that like we don't have the evidence to be concerned. And so I just tell people to try to design it in the right way. You know, perhaps somebody will, and this is maybe something for people in research ethics to do, is like to actually do a study specifically on that issue. But nobody's really done much on it. People have written about it and about the concerns about sort of the ethical issues that underlie it. But they're relying on, you know, whether or not people, like the research in psychology about people lying and et cetera, and sort of saying like, this is kind of what we know.
We had colleagues with a study, it was a pregnancy study, and it was all online, and lots of people lied about being pregnant in order to participate. Like you said, it's going to happen.
It's going to happen, yeah. You know, when you go to something that actually is above minimal risk and is doing something like providing actual care, well, you're going to validate it because there's a care relationship that's already established. And so you're going to do some sort of linking and validation to a pre-existing relationship with an individual who's a primary care provider or with an institution. And then how and where you do that check, that's interesting. And I've been encouraging people to really innovate around that because I think there's way better ways we could probably come up with doing it. And to make it easy and to protect people's privacy and kind of do it right. But we don't have a lot of studies that are doing that yet. And when we do, oftentimes it's really easy because, you know, it's going to be something like, okay, we're going to give you this app, and it's going to be an app that's going to do a whole bunch of tracking and reminders and other things after you get a stent. Great, sounds good. Abbott Vascular would probably be super excited to have something like this, right? And so you say, okay, well, you're going to sit down with your cardiologist frequently anyway, and your cardiologist is the PI in a study, so maybe the easiest thing to do is there's a PIN code the cardiologist can put into the app to actually activate it. And so they're sitting there right with them because you already see them. And so take advantage of the inefficiency of the fact that like we really do have to see one another person to person sometimes. So I think a lot of these things can be sorted out with much simpler implementations. So let's talk about some more risks. So this is one, these two are like sort of fun, the Hawthorne and anti-Hawthorne effects. And this is, yeah, so we kind of know that like we're being watched and so we behave differently. I think the entirety of adherence, research as well as like patient engagement stuff is like making this crazy bet that the Hawthorne really works way better than it does. It's like, well, if we know people are watching us, maybe we'll get healthier. And like we kind of know that that's not true. It just doesn't really work that way. And so, you know, in some ways, some of the outcomes that people have for digital health research is like, well, if we monitor them more, they will get healthier or things will happen. And so we're going to change their behavior because they know they're being watched. Great, that could be a bias that could happen. That's pretty old school. It's the anti-Hawthorne that I think is sort of fun and interesting, which is, well, I knew I was being watched, but then I forgot. And it's collecting all this information on me and sending it back to people. And like, I kind of, maybe I'm not so comfortable with that because I kind of forgot. And then now it feels a little weird because I picked up my phone in the middle of the night and realized that like it had tracked me over to the bar, and then it had tracked me over to Cosmic Cantina, and I was really trying to be good about my diet, and like now it's just a reminder that I had Cosmic at 2 in the morning. Right, so this is the kind of thing where we can forget, and the technology is still doing it. I think there are some cool solutions and approaches people can take with this. And this comes back to the fact that we can do really good informed consent again. I think we can reconsent people more. I think now that we have better tools to do consent, we should reconsent because it's easier to do. It doesn't require your study coordinator to sit down with 500 people again over the next year to redo all of it. If you have a remote system, you can say at 6 months or 1 year, the system is automatically going to reconsent somebody. And so we can do a better job on the research ethics of reminding people what they've signed up for, reinforcing it, and reconsenting them. I'm super excited at the idea of doing this, and I'm like hoping somebody wants to do this so we can try it. Because I think it's one of those like windfall moments where we can do something really great. So I want to see reconsent, and I think it can help with things like, you know, hey, like, just so you know, like, we're tracking your every movement, and we know where you're going. Are you okay with that still? You can do it on the iPhone with notifications and reminders and all sorts of things. So there's lots of technical solutions to actually do that. The next piece is about the blurring of minimal risk and greater than minimal risk. This matters to me a lot because some of it is actually a little bit frightening. We have a number of different people who are trying to do really big analytics projects on insanely large amounts of data. I think that's wonderful. You know, having learned a little bit about machine learning and about predictive analytics and like how to do that kind of stuff, There's a lot of power in it, although there's a lot of places that like to throw those words around and then not provide any value. But it's still one of those things where I think we have a lot we can do. However, if you're going to say, cool, I want to do a machine learning project, but I'm going to take the, I don't know, 25% of UNC Cancer Center's EMR system, and I'm going to upload 25% of all the patients' records in their entirety into the cloud, and then I'm going to, from there, use IBM Watson's tools on predictive analytics and machine learning to actually analyze a whole bunch of this data and then pull out some patterns. Scientifically, this makes sense, right? This is like what you would do. You've partnered with them. You're part of IBM Health, IBM Watson's ecosystem partner. You get access to the tools. They're, great. However, you just took 25% of an EMR and you just put it on the cloud controlled by an entity that is not your entity. This technically under our regulations would be considered a minimal risk study that could be approved under expedited procedures by an IRB. It is technically that way. It's 25% of an EMR. If you, for any reason at all whatsoever, there was some sort of breach, it would be the largest HIPAA release in recorded history in the United States. I think we have to have a conversation about whether or not that's really minimal risk or greater than minimal risk. Because it's massively efficient, but it could be massively problematic if something happened to it. Do I think that that's going to happen? God, I hope not. Of course I don't want that to happen. But we just have to think about what would be the magnitude of problem should something happen, and are we doing enough to control for this, and are we adequately, sort of informed about the safeguards and the measures we're doing it? How are they transferring the data? Are they doing the data through an FTP site? Are they uploading the data directly to the cloud? Is one of these places FSMA compliant? Like, that's like the big thing that quintiles and like the CROs like to do. Are they holding the data aside? Is the data put in a separate place? What's the redundancy on it? So we don't have these conversations yet. And IRBs really don't have them because they don't have the technical expertise to even ask some of those questions.
That's what we said in privacy officers.
Right. But these are the kinds of things that we need to think about. Technically speaking, that's a really easy thing to do. But there might just be some solutions that are better ways to do it. Like, okay, we're going to talk to the head of IT at the institution. We're going to put it onto an encrypted flash disk, and then we're going to physically take that flash disk to New York City, go to Astor Place, go to Watson Health, and then we're going to directly upload it. And they'll be like, but that will cost us an extra $500 for round trip ticket to do it. But like, yeah, but then we can be absolutely sure that the data was transferred in an appropriate way. And we don't have to worry about any cybersecurity threat, period. Right, this is actually how they like transfer data in diplomatic pouches still. Like they literally like little USB key, and it's like we just like fly it to Dubai and like hand it to somebody. So, but we have to just be thinking about these kinds of things. I don't pretend to have all the solutions, but I just want to bring it up as the kinds of stuff that as a community we have to discuss and think about, and then try to solve it in as easy a way and as durable way as possible. Okay, so this is the piece about mandating information. In the UK and also in Europe, they've like gone way ahead of us on this. They kind of got it, and they started to do things that were a little more pushy and specific. What are you mandating or forcing people to do in order to participate in something? We oftentimes have things that are optional versus things that are required, and we have to be careful and thoughtful about what we mandate and what we force people to do. Oh, well, in order to be in this study, you have to disclose and then a laundry list of things. Is that always okay? If you're reviewing it, do you really need it? The mentality of people that come from consumer technology backgrounds is usually, give me everything, give me all of it, give me now. This is like the Facebook idea. I want every piece of sentiment data I can get about you, and then I'm going to use it in whatever ways I want, and I'm going to get consent for it. Well, actually, no, it's Facebook. I'm not going to get consent for it. And then, we're going to go on our merry way. That is absolutely the opposite posture and understanding of HIPAA. HIPAA is grab the minimal amount of information necessary to answer your research question. And you have to justify what you're asking for. And so we have to be a lot more disciplined about doing that and saying, what are we grabbing? Why are we grabbing it? How are we justifying it? And so we just have to be careful about that. And we have to teach our partners that come from a consumer tech background why that's important. The place where this gets really funky and confusing is machine learning. Because if you're going to say, well, the whole point is more data and more types of data allows us to do a better machine learning process. That's true for the way that that works. But you need to be able to broadly describe both the buckets of categories of type of data that you would use as your inputs, as well as why those would be largely important for the analysis that's being performed. And I've seen very few people write this up really well, but we need to push for that so that the science can be done and done appropriately, and they can get the data that they truly need in order to do the analytics that's important, but also we understand that it is actually the required and necessary pieces for it to be accomplished. Yeah?
What I was curious about, you're talking about machine learning, is with the implementation of wearables, there's a lot of data that we're able to collect now. We have no idea how it actually impacts our ability to predict these data.
Yep.
Because nobody's ever been able to tie this data to an outcome before.
Yep.
Is that something that you think is going to be a big challenge with pushing through, like proposing to an IRB, and the IRB says, well, what's your justification? Because there is no justification.
You just gave me half of it, though.
But they're going to say there's no precedent.
They were reviewing research. There's usually no precedent. But if there is, then they're going, why are you repeating something? No, but you gave me half the answer, I think, which is you said, we've never been able to collect this kind of information, and we have yet to be able to tie it to an outcome. But we're looking for that, right? And so you say, we're looking for it, and here's the analysis we're doing, and here's how we're doing it. So that could be part of, like, this is my statistical analysis, right? This is my plan. I'm going to do machine learning. This is how I'm going to do it. These are the types of information, the data types we're going to get. These are where we're going to pull them from, and this is what we're going to look for and how we're going to approach it. And this is why. And so if you're able to articulate that in a very clear way, it explains the justification for every data type and piece of information you're collecting. And that becomes very critical. Because most people, they don't understand what the inputs are for a machine learning process and how it works. It's not easy to describe to people who don't come from a computer science background. But we need to put the challenge back on our informaticists and our computer scientists to come up with that language to describe to people. Otherwise, we're going to have a problem. You're going to solve this.
There's a professor in computer science here at UNC Shire who some of his work is to take audio that someone's getting and then sort of filter out everything that's not relevant. So you might be hearing someone's voice when they're talking, but you might also be hearing their TV in the background or all these other things.
Yep.
So that's sort of a technological solution towards privacy by
yep.
finding the signal in the noise and cutting everything else out, not sending it.
Yep. And you could, if you have easy ways to connect that through an API to do it for voice recordings for something, that would be really helpful. For example, there's somebody, I forget what the study was, somebody wanted to start recording people's breath in order to understand whether they were having breathing issues. And so they wanted to use the microphone on an iPhone to take recordings of it. But you could have a whole bunch of other sounds. Like, I live in Manhattan, and like, depending on where you are, the sounds around you might locate you. It's like, oh, there's a lot of really strange sounds of people playing music and stuff in the background. He must be in Washington Square Park, right? So that kind of stuff will actually be really helpful for people. Okay, so this, one of the areas that I've spent a bunch of time in my career on, being somebody with a disability and having worked with disability advocates for many years, has been around vulnerable populations. We have specific regulations in our stuff for human subject protections for vulnerable populations, and I think people don't think this through very well. And we definitely don't have an understanding within digital health how we're going to either recruit or include or provide benefit and value to people who are vulnerable in many different ways. And the first way I try to get people to think about this in terms of their use of technology is how many people in this room have a Facebook account? All right. How many people in this room use Snapchat? Right. 1, 2, 3, 4. Yeah. Let's say less than 20%, right? What do you think the rate is and the amount of people that are under the age of 27 is that use Snapchat versus Facebook? Yeah. Really high. Facebook basically means you're old. And I'm old, apparently, I use Facebook. I had one of my students taught me how to use Snapchat. It was so precious. And I was just Alina, I don't get it. It all goes away. And she's like, that's the point. You know, and then I was like, how do you take screenshots of it? She's like, you're not supposed to. You know, so it was, but that's what I mean. So it has, we have to have this understanding of like what our own biases are and like what people are doing. And so most people in a certain demographic are using Snapchat and they're not using Facebook. Great. If you're going to be recruiting people, and I haven't seen anybody do this, I would love to see an opportunity. Are you going to recruit through Snapchat? Has anybody thought about how to recruit subjects through Snapchat? Has anybody done it? I know I hear a lot of whispers, like, oh, God. Right? So, you know, the Facebook thing is like an approach that people have been using. But what about Snapchat? What about Vine? You know, you name it. So these are the kinds of things that we just have to be thinking about. We also have to think about the consequences of doing this. If you're going to run a study that you're going to be contacting participants through Facebook or some other social media, what happens if somebody figures out that they're in it? What happens if it's a child? What happens if it leads to cyberbullying? What if it's for pediatric depression? Somebody figures it out, hacks their account, or sees it over their shoulder, and then ridicules that person until they attempt to take their life. This is not unheard of. That is a variation of the story of what happened in New Jersey, right? This is stuff we have to care about, and this is stuff we have to think about. The internal lives of people who are millennials or Zs is different than those who are Gen X or elsewhere. We have to think about it, not only for us and for how we help health, but for them. So this is something we have to be very careful of. We also have to think about it in terms of both group-based definitions and situational definitions. People bring devices that have access to the internet everywhere. What situation are they in? Are they going to be completing a study visit while they're at school? If you're at school, does FERPA apply? Oh, who knows what FERPA is? Right, who doesn't know what FERPA is? Exactly, right? So we have to think about these. We have both regulatory issues as well as like these, you know, these sort of larger, broader ethical issues. I like to focus on the ethical ones because I think they're a little more memorable and it puts people in the position to ask good questions. FERPA is the Federal Education Records Privacy Act. I think I got that right. And it's basically like the thing where you ask somebody, ask a school superintendent about something horrible that happened at their school, and they're like, I'm not allowed to say by law what goes on in this place. Right, that's because of FERPA. And so we protect the records and the identities and the information about people when they're in public institutions and public schools. So we have to be careful about that kind of thing. I don't think we can control for it. I think it's like virtually impossible to control for some of this, but we do need to be thoughtful about the interaction. Yeah.
Do you find that researchers are responsive to that? Because that's something that I would say that topic comes up all the time with research, where I keep saying, you're talking about this like they're going to go home and take out their phone on their couch and do this thing, but they could be at the grocery store, or they could be at their play date, or they could be at work, and they can be anywhere. Yep. And I find that often people haven't thought about it that way.
Yep, they haven't at all.
Like, oh, well, we were thinking they would, you know, they would do it at their house. It's like, no, we use our phones everywhere we are.
Our regs aren't even written that way. So I'm constantly telling people to think about situational vulnerability as well as characteristic. Our regs are written such that the vulnerable populations that they say are like pregnant women, infants, neonates, children, prisoners. You know, like we think about it as characteristic based instead of situations. People have different situations that they come encounter with throughout the day, throughout their lives. The way that we live our lives is different based on the different developmental stages, the different places and things that we do throughout the course of our lives. And so how somebody behaves in the situations they find themselves in are different when you are 15 than you are 25, then 45, then 65, then 85. And we have to design solutions that meet people where they are and acknowledge that and then take that into consideration. It means that functionally as researchers, you have to know your subject population really well. And you need to be able to write really good descriptions about who is it that I'm doing this research on? And what do I know about them? And if you have like, you know, oh, it's going to be anybody 18 plus. Great. What do I know about anybody 18 plus that could possibly, I mean, it's like you have to just think about this a little bit. So that's kind of where this is going. It's like there's a lot broader context that we need to think about. This doesn't mean that we shouldn't do certain things. It just means we need to be thoughtful and ask the questions and do the best we can.
Probably educating study subjects too. I mean, this has come up with a lot of our mobile things. Like, don't use it while you're driving. Well, duh.
Yeah.
But in giving that education, or like, don't do this if you, there's a risk that somebody might see you doing this, or there's a risk you might slam into another car if you're responding to your study questions in the car.
Great.
You're on your school laptop.
Yeah.
Don't talk about your HIV status and do this questionnaire while you're on the subway, and that there's 100 other people and somebody could be looking over your shoulder. Why? Well, to protect you, because you may not want to disclose. You may not want it to be inadvertently disclosed. You don't want these kinds of things to happen, and so we just have to remind people. So there are some things that I still like to point out that are sort of annoying or stupid or bad. And it just kind of shows you that even the people that really care, I think that people at Apple care. I've had a few conversations with Michael O'Reilly, who does their medical technology stuff, and a few others, and they're not doing this stuff because they don't care. They really want to get it right. But that doesn't mean that this stuff all works yet. And so this was this time that I sort of asked Siri a couple of questions, and as you can see from left to right, I got increasingly useless answers, right? And this may actually be different now, so they're constantly kind of doing this, and because of the people that have seen these slides in the past, I'm sure maybe someone there might have said, ooh, this looks bad, maybe we can do something about it. So if anybody wants to, please go ahead and check and see if it's changed. I won't claim credit, but I think it's just sort of interesting. So when I ask this, Siri doesn't know tone, right? Siri can't tell if you really are clearly asking these things and mean them. I could be joking and ask this and get these responses and be like, it's funny, Siri doesn't know anything about depression and has really bad responses to it. But these are 3 ways of asking for help that escalate. The first one is a benign one. The second one would be somebody that would potentially have moderate depression or might be about to be triggering a pretty bad depressive episode. And the third one is a clear problem. If you mention actual harm to yourself, this is the point at which the recommendations within psychiatry are you got to talk to somebody, and if you have that, you recommend somebody go to the ER. This is not the point where you say, let me do a web search, right? But there are other solutions that exist that use digital technology that can help with that. Here's one of them: crisis text line, free texting, mental health counseling, on demand, 24/7. All I gotta do is text this number. It exists. It's already out there. So this is just to kind of give you a sense that some of our approaches probably not so good, and that we might have other things that we don't know about that exist that actually can do things. Okay, the last piece on the real hardcore research ethics part of it is justice considerations. And this is where I think we have both good and bad, but really primarily good. We can blow out of the water access. Someone can be in Pullman, Washington, or in Placerville, California, or in a rural part of Montana, north of Bozeman, and they could be part of a study. We can provide access in an unprecedented way. And that's a really good thing. And we have some issues that come up, and there's challenges with this as well. We also have some platform issues. And so this is that demographic. How many people in this room have an iPhone? How many of you have an Android? Okay. Most of the stuff is for iPhone. What about Android? Android actually has a larger percentage of the market. And so why are we doing things that are primarily going to be for white upper middle class people that are part of a certain generation and have on average an annual income of at least $85K to $105K? That's not going to solve healthcare problems. I would call that a justice issue. I would call that actually a travesty, because we need to provide solutions that go after a catchment area that is not Silicon Valley. It needs to be for society. It needs to be for the larger public. We need to be developing a suite of technologies and tools that actually address issues for everyone and meet them where they are. So it can't just be the really slick stuff in ResearchKit on the iPhone. We have to do more. So I know some people who are trying to do this for Android, for ResearchStack. It's kind of hard. They're having trouble. They've only got a few things that are sort of coming out. But we need to make sure that we don't leave out basically the rest of society, because most of it's not going to be at this very high end. But we can use the great stuff we learn at the high end to have better stuff for everybody else. So I think that justice consideration just needs to be acknowledged. So a few cautionary tales, and I'm cognizant of the fact that I'm going over time. A few cautionary things. Don't recreate the same problem. We've covered this, I think, over and over again. Don't recreate the same broken healthcare system all over again. try to address things that have been nasty in the past by using technology efficiently to solve them now. It takes more effort. You have to stop. You have to think it through. You have to create stuff that previously didn't exist. You have to fight that urge to do it the easy way and just repeat a process that's already sitting there in front of you. I say this for people who try to do innovation around clinical processes. And they're like, well, this is the way we do it. Can't we just create like a phone that does that? I'm like, is the way you're doing that actually right to begin with? Do you really want to be that inefficient? We have to stop and ask ourselves the question of whether we're just recreating the same broken thing. It's all about the data. We talked a little bit about this. The who, what, where, when, why, and how of the data. You kind of have to know where you're getting it, what it is, who's getting it, how it's being shared, you name it. So we really have to focus on this way more in digital health than most other things that we're worried about. And we have to describe it really well. Non-compliance. Really efficient technical systems can create really efficient non-compliance. And so you can say, ooh, I can do that, and I can do it faster, I can do it immediately, and I can do it automatically. And if it's wrong, I just did it 500 times wrong in less than a second. This is really a problem. So we have to be thoughtful about, okay, if somebody basically red teamed what we're doing, like if you tried to break it, how would it break? And would it break gracefully, or would it break in such a way that we would have a huge headache? Would it break in such a way that it accidentally discloses the names and email addresses to all the participants of all the other participants? And how many people do we have in the study? Oh, we had 700 people in the study. Congratulations, you've just crossed over for HIPAA, the mandated reporting to the media that you had a HIPAA disclosure. Your institution is going to get its credit rating dropped. This is a problem. So we just have to be really thoughtful about non-compliance. Jurisdictional issues, whether you're doing IP limiting so that things from other places can't come happen to this. By the way, in the first 4 ResearchKit apps, Apple screwed this up. Oops. It went into the App Store by mistake into a couple of foreign countries. They found it quickly. And we got rid of it, and we identified the people who had enrolled or whatever, and took it out. But it was definitely something where we didn't know. The platform happened. The platform being the App Store or Google Play. So there's that kind of stuff, a little worrisome. We just have to be really thoughtful and careful about it. And the rules in different places. We have different laws in different places. You can consent in New York State. You can consent for certain types of medical procedures as an adult if you are a minor. They have a carve out for adolescent health for things like reproductive services and other things like that, where you can do it yourself. You can go to a clinic, you can get treatment, and your parents never know, and they don't have to know. But that's not true everywhere. And so let's say you wanted to do a digital health intervention for that category of people. If it's directly related to those services, we can actually approve something as if they're adults and they're minors. That can't happen in almost any other state. So we have to be really cognizant of the local laws. So this is the best practices and recommendations, also known as here are the SOPs that you can copy and paste and try to use. And so I have a whole bunch of them here about how you write your protocol. Put in tabular and graphical form all the data so you can map it out so you can describe to people. Remember, the people at the IRB are overburdened and they don't know everything that you do. Teach them. And when they ask you questions and you're annoyed about that question, take a deep breath and remember that they care and they want to help you, so we'll work with them. And we have a number of other ones here as well that we can go through, but this was the slide that I think people usually wanted. Here is the who, what, where, when, why, and how of your data. And these are all the sort of questions that come up for each. And so can you answer all of these questions for the different data? And can you put it into a table that's sort of clear so that people know, so they can assess it and evaluate it and go, wow, you did a great job and you thought through all of this. Wonderful, I'm approving it. But it also, if you do this, it's a forcing function for you to go through all of this and prove it to yourself that you've designed everything else. And that's hard, but it's helpful. It actually improves your study designs. I think that we need to have IT developers and others on IRBs as voting members. I've been saying this within the IRB community. We've gotten to the level of sophistication where we need that to occur. And there's specific things we can tell them to do that I think would be helpful. And I think it should be mandated. We could mandate it internally as SOPs everywhere. We could do the thing that would never work, but we would love to do, which is mandate it in our regulations, that they include this kind of perspective. But it is broadly covered under the you have to have the expertise on the board to review stuff that's coming to you. So I think this should be done. We're past the point where that needs to happen. These are just for the IRB people. It's a lot of the same things, telling people to make SOPs, to get the expertise they need, to push investigators to map stuff out really well. We also need to be cognizant of the fact that we can't have people spend $300,000 developing technology and then have the IRB go, please change half of that. So we have to come to a happy medium where you like submit all of the language that you know is going to be in there and maybe the wireframes of what you're going to build up along with a detailed understanding of all the data and everything else so that you can actually write that ahead of time. Get that approved. And IRBs need to approve that so that the proof of concept and all the detail is there and then they go build it. Because I think it's impractical and inappropriate to make them have insane fiscal consequences when the IRB changes something. And so both sides actually have to come in on that. The researchers needed to have much greater detail in their protocols in order to prove to the IRB that the IRB will give them approval before the actual technology is built out. And so that's a combined coming in the middle. Overall recommendations: be a better collaborator, evangelize to one another, write SOPs, recognize that this is hard but super interesting, and we should be teaching one another and advancing things forward collectively. Acknowledgements: a whole bunch of people that I work with at a variety of institutions, Memorial Sloan Kettering. There's a project I'm working on. I'm the executive director for to do population screening in 4 major metropolitan centers for founder mutations, and our collaborators on that. LifeLink, which is one of the companies that we've begun to work with, my business partner and others. And then some people on the research ethics side, people like John, who's here, Charlotte Coley, who's here, who I worked with when I was at Duke, who's in the IRB here, and Bruce Gordon, who's an IRB chair at the University of Nebraska and a pediatric hematologist oncologist. Many of us have been trying to help one another figure a lot of these issues out, and so it's a community of people that are really trying to advance it forward. And with that, steal, adapt, use it. If you have questions, I'm happy to help people with it. There's few people really trying to do this work, and we all kind of have to help one another no matter where we are in the U.S. So, take some questions.
Thank you so much. So given the timing, I think maybe the best way to go is, do people would show of hands, everybody want to have question and answer, or like random time part? I think this is what we should do. If somebody wants to do question and answer, they can gather around this area and ask Jeremy questions, and if they don't, then they can go and gather and do whatever else they want to do. Does that work? Or do y'all want to do question and answer? All right, thanks. Thanks, everybody.